The informant is the patient and the information is not reliable.
Why is the information not reliable?
Okay, because number one, he doesn't remember, doesn't his memory.
Are you sure? Did you assess the memory? The patient, okay?
Information is logical.
Okay, you should have added it that the information is not reliable because the patient was not coherent during the interaction. Just give a brief reason why you think is reliable or not reliable.
Presenting complaints. Patients complain of seeing people and hearing voices which others don't see or hear in clear consciousness. The concept of and progression is unknown.
No. How many presenting complaints do you have? No. The patient is not going to tell you I'm having auditory hallucination. The idea is that you present the presenting complaints in the words of the patient. So in the under your presenting complaints, I expect to hear bam, just you don't need to start explaining hearing of voices of unseen persons, something like that, or just hearing of voices. Then the next one is what?
And seeing people.
That's not how to frame it. Seeing strange persons or seeing strange things. Hearing of strange voices, seeing of strange people or strange things. What else? Which other presenting complaints? No. Are you still under presenting complaints or history of presenting complaints? The idea is that after you've read out your presenting complaints, somebody who has an idea of psychiatric disorder should be able to start thinking. It could be this, it could be schizophrenia, it could be bipolar and all that. We usually encourage that you have like up to 3 presenting complaints or 4 presenting complaints. The patient must not tell you all the presenting complaints. Even during the course of your interaction, you can still pick out things that you think can serve as presenting complaints. Do you understand? And bring them up. Anything that when somebody has a glance on it, the person should be able to say likely this or likely that. Do you understand? And you frame it in a way, in a psychopathological manner. I don't frame it like a market woman. Do you understand? You use psychopathological terms. Are you hearing what I'm saying? Yes. I say hearing of strange voices or hearing strange voices in clear consciousness, seeing strange things in clear consciousness, suspiciousness. Do you understand? Even though the patient might not tell you that, but if you, in the course of your interacting with the patient, you see something that looks like, so you know that, how do I put it now? Paranoid delusion or paranoia is a major symptom in psychiatry. I'm just trying to tell you how to synthesize presenting complaints. Presenting complaints, yes, primarily you drive it from what the patient says, but you have to paint it in a psychopathological manner. You don't just say it like a market woman. You use your background knowledge of symptomatology of mental. They've taught you signs and symptoms of mental illness. Did they teach you that? So, like in schizophrenia, you have what are the signs and symptoms of schizophrenia, for instance? Hallucinations. But now, the difference is that hallucination is a technical term. It's a term associated with mental state examination. Even though the patient presents to you as hallucination, you're not going to say hallucination. You're going to paint it in a layman's term. You can say hearing of voices, hearing of strange voices of unseen persons. If you want to make it more robust, you can say hearing of strange voices of unseen persons in clear consciousness, seeing of strange things. Do you understand? Then delusion is another symptom, but delusion is a technical term. So the counterpart in symptomatology in presenting complaints should be suspiciousness or false accusation, falsely accusing people. These are some of the things I want to hear in the presenting complaints. Falsely, do you understand? Aggressive behavior, do you understand? You won't say fighting. It's too watered down. You have to use those technical terms. Do you understand? So, and the idea is that after reading out your presenting complaints, your listener should be able to have an idea of where you might be going to, and that's actually what should also guide you, because after the presenting complaints, you have a kind of guide of how to take the history, where to concentrate more on. Do you understand? Assuming somebody presents with hearing of strange voices, not even seeing of strange things, because visual hallucinations are not too common in a functional psychiatric condition. I hope you are aware. By the time you start hearing of visual hallucinations, it's possible that there might be an organic issue going on, or maybe substance-related issue. But for core psychiatric conditions like schizophrenia, bipolar disorder, you're more likely to have auditory hallucinations. You understand? By the time the individual presents to you as, having hearing voices of unseen persons, suspiciousness, aggressive behavior, social withdrawal, your mind is already tending towards maybe schizophrenia. But when you now come to the history of presenting complaints, after characterizing each of the symptoms, you now try to tell your listener that this is likely schizophrenia. You now begin to ask other questions to elicit other symptoms of schizophrenia, to add up to what? These are associated symptoms. So in the history of presenting complaints, first of all, characterize each of the presenting complaints. Characterize it, how it started, the cause, the severity, the dysfunction that is associated with all those things. You pick it one after the other. Then after that, based on what you're thinking, you now start to ask for other associated symptoms. What it means is that you have to have the symptomatology or the how schizophrenia presents for you. You have to have it at your fingertips, so that you know the ones that are remaining. And you now start to ask, because there are some that might not be volunteered by the family member or by the patient. After characterizing the presentation, you should now be seen asking for all those other associated symptoms of the disorder that you think it is. For instance, schizophrenia. That is ruling in. Call it ruling in. You're ruling in, bringing some other associated symptoms to support what you're thinking of. Then, after you have done that, you now do ruling out. Do you understand? For instance, there are so many psychopathologies or psychopathological conditions that can present with aggressive behavior. Somebody who is manic can be aggressive. Somebody who is delirious can be aggressive. Somebody who is intoxicated can be aggressive. Do you understand? After ruling in, you now start to rule out. You've said it is likely this, but it's not this because. So you start hearing things like, this illness is not associated with, what's it called? It's not associated with sadness of mood. There was no pre-existing medical condition. There was no associated head injury. You're ruling it out. That's how it goes. Do you understand? How many presenting complaints did you actually characterize it? How many presenting symptoms do you have there? Do you have written out clearly? Please, at any point in time, if you have any questions, ask me.
I have a question. It was like sometimes you'll be hearing people discussing. I asked her, is it how many? You say two people that they are discussing about her. In this presenting complaint, you say you are not just going to write it like that. Is it this suspicious this that will put?
No, you can't. If from based on what the woman told you, you can extract hearing of strange voices, or you can say hearing of strange in your presenting complaint. Then when you now come to the history of presenting complaints, you now characterize it. You now paint the picture, the psychopathological picture. Do you understand? Any other question? Are you following? Now, remember, it is not everything that you put out there as part of presenting complaints. Now, before somebody starts to talk about, that thoughts are being inserted. In fact, most times patients don't volunteer that. You need to elicit it. Psychopathology associated with thought insertion, thought withdrawal, they are better left at the mental state examination, unless the patient volunteers it. But it's unlikely. Do you understand? But if the patient volunteers it, he can say believe that his thoughts are being manipulated. Leave it at that. Believe, not feeling. We're very careful about the choice of words in psychiatry. Because if you say feeling, it means another domain of mental function, which is emotion. When you're describing thoughts, anything that has to do with this, you say the patient thinks, the patient believes. Do you understand? not the patient feels, just like you use in your normal English. No. Once you say feels, it means that you're already talking about another domain of mental functioning, which is emotion. Do you understand? Because mental processes are divided into, you have perception, you have cognition, you have emotion, you have behavior. These are the domains of mental health functioning. So you cannot be talking about, for instance, perception now. You say patient thinks. You say patient sees or patient hears. You understand? Use the appropriate term to characterize it. Any other question? So let's go back to, I said under your PC, not HPC now. How many symptoms do you have based on what you wrote down there? Who classed the patient with you? All of you. How can all of you class? So, but at least before you come up for this, you should have a consensus now. Do you understand? Did you write out the PC? Did you write it out?
Yes.
So read them out. How many pieces do you have? Fever. I'm not clerking psychiatric patients. Is it fever that brought the patient to the hospital? Well, I also understand your difficulty because you took the history from the patient, and I think that the patient has not settled down, right? The patient is not coherent, so that's the difficulty that you might have. In fact, you can actually see such cases in the exam. For people that want to train in psychiatry, maybe residents, they can give you a patient that is not settled, and you might also have language barrier, and it is still expected that in spite of all those limitations, you should still be able to extract. The most important thing is to know the information you want to obtain. Taking history is something that is organized and methodical. You know what you're looking for and you go for it. Even when the patient is veering off or the patient is circumstantial, saying things, you always come back. Just like when you look at the patient, most of the patients that will have you are schizophrenic patients, right? Even from their fashion. That gives you a background and that guides you. So that you don't, it's not every history or everything that the patient says will bring it up. Do you understand? Like these other things that will not help you making that you can, if you think it's important, you can leave them at the association stage, not presenting components. But read your history. Let's see.
Hearing voices and seeing strange. So for the issue of presenting complaints, I couldn't get much.
The idea of history, just like I explained, the idea of a history of presenting complaints is to pick each of the pieces and characterize it, each of them. Just like you said, hearing of strange voices. So look at how it goes. Just like in general medicine, the patient was apparently well until about so and so days ago or months prior to presentation, when he started having strange experiences. Do you understand? You can open it like that. This started with hearing of strange voices of unseen persons in clear consciousness. That's how we say it. Hearing of strange voices of unseen persons in clear consciousness. Not just, you don't leave it at the PC level, you can say hearing of strange voices. It still does not nail the psychopathology. Somebody can hear strange voices, but how? What makes it a psychopathology is that the person hears these voices in clear consciousness. It's not as, of course, that's why you have to find out whether maybe it's associated with dreaming or whatever. You must be seen to establish that these voices are heard when the patient is awake. And now these voices are also heard through the ears, not from the mind. Not obim, it's not mind. It's through the ear. And how you ask it is that, are you trying to tell me now that you hear these voices through your ears just like you're hearing me? Now to make it clear. That is what makes the psychopathology. Read what I can see that you're writing something. Read it. Okay? You know, we're just painting a hypothetical scenario. Do you understand? You can apply that to other aspects.
A few days prior to presentation, when he started hearing, having strange experiences. This started with hearing strange voices in clear consciousness.
Now, is there another thing? Sir? Hearing of voices of unseen persons in clear consciousness. Now, these voices, he explained, he hears through his ears. Do you understand? Through his ears. Then you can also go ahead to talk about whether the voices are distressing or non-distressing. Some will tell you the voices are distressing, and that's why at times you see some of them, they will block their ears. Whereas others will tell you, they are telling me how good I am, they are telling me I'm a king. For instance, somebody who has mania, do you understand? When they begin to have psychosis, mania can present with psychosis too. So at times they can have mood congruent psychosis. They are hearing the things that are in conformity with what they believe. They believe, a many patient might believe I'm a king. You might hear a voice that reinforces that. Do you understand? In that kind of a situation, you see that the voices might not be distressing. Do you understand? But compare it with somebody who has schizophrenia associated with more of positive things. Which people attended my lecture? Now, we talked about domains, symptom domains. Compare that with somebody who has schizophrenia and the patient is hearing voices abusing him or her. Do you understand? It makes more sense. Somebody that has more of paranoia. Do you understand? We talk about the fact that the patient hears voices of unseen persons in clear consciousness, the fact that the patient hears these voices clearly through their ears, not through the mind. We talk about the nature of these voices. Are they acceptable to the patient? Are they accepted by the patient, or are they distressing to the patient? Do you understand? Now, we also talk about the timing when these voices are commonly heard. You know why it's important. Have you heard about hypnagogic hallucinations? Hypnagogic and hypnopompic hallucinations. Can somebody tell me what they are? Hypnagogic hallucinations. Can you tell me the classic neuropsychiatric condition that is associated with hypnagogic hallucinations? Classical one. Have you heard about narcolepsy? Narcolepsy. Who taught you that? Is it in neurology? Physiology? So, of course, in narcolepsy, can somebody remember what narcolepsy is all about? He said? Urge, yes, which can manifest as catalepsy or cataplexy. Which one? Is an MCQ. We are talking about narcolepsy. Do you have cataplexy or catalepsy? Do you know how you code it? It's the opposite. Narcolepsy, cataplexy. Do you understand? Just code it that way so that it doesn't. In cataplexy, somebody suddenly loses muscle tone. There is loss of muscle tone and the person falls to the ground. And this is usually triggered by intense emotion. Whereas narcolepsy, catalepsy is seen in what? Catatonic schizophrenia. I don't want us to veer off because we have a lot of things to talk about. We started talking about narcolepsy in the background of types of hallucinations. I was trying to tell you that it's good that you find out the timing, whether the hallucinatory experiences have timing. For example, in narcolepsy, just like she rightly mentioned, that you can have hypnagogic hallucinations. Hypnagogic hallucinations. And we said that narcolepsy is a neuropsychiatric disorder where you have, what you have there is intrusion of REM sleep. Intrusion of REM sleep that interferes with normal wakefulness. Do you understand? REM sleep is supposed to occur in sleep. You have REM sleep and non-REM sleep. In non-REM sleep, the brain is active, but we have motor atonia. The muscles are paralyzed. Can you remember that? When you have intrusion of REM sleep in consciousness, that is the hallmark of narcolepsy. But there are other symptoms of narcolepsy. Do you understand? Let's not veer off. Let's not veer off because we have a lot of things to talk about. That's why it's good to find out, is there any particular timing of these hallucinations? And remember, for you to zero down on functional psychiatric disorders, you must be seen to rule out neurological issues, organic issues. If somebody presents with hallucination, you want to know, is there any particular timing? If this hallucination is commoner when somebody is falling asleep, you know that it gives you an idea that you might be thinking of something else. That's why we are doing all these things. How many characteristics now have we mentioned?
If they hear the voices through their ears or their mind.
One, the timing. So, and you can also go ahead and ask what they do about the voice. Do you understand? And you can also find out, another thing is that very important that we've not even talked about. We have second person auditory hallucination and third person auditory hallucination. The second person auditory hallucination, the voice or the voices are saying you. The voice or the voices are referring to the patient directly. You're a fool. You're a stupid person. Look at you. Do you understand? Whereas in third person, the voices are talking about the patient. They're using he or she. Do you understand? He has started again. Look at him and all that. They are discussing in the third person. Yes, something like that. You also have to find out how many voices do you hear and what do these voices say. By asking how many voices, usually once you have more than one voice and they are discussing the patient in the third person auditory hallucination. Now, there is also a particular type of second person auditory hallucination where the voice or the voices are commanding the patient. Command auditory hallucination. The voice can say, see your enemy, go and finish him up. Do you understand? It's an instruction. When you have command auditory hallucination, you also have to establish whether the patient obeys it or not. So if the patient obeys it, it means that it has an import. What does it mean? It means that the patient is dangerous. If you couple command auditory hallucination with persecutory delusion, it means that the patient is dangerous. If the patient is told by the voice, see your enemy, this is the person that is responsible for your failure, why not finish him up? And the patient is used to obeying the voices, that means the patient is potentially dangerous. These are the things that you talk about the voices. That's what we talk about, characterizing the voices. You must be seen to characterize each of these things that we mentioned. So that's about that. There are other, and they again, of course, what the patient does about the voice. Some block their ears with earpiece. Some will close their ears, especially when the voices are distressing. Some will be uncomfortable. Some will start to act out and all that. Let's look at a patient that has typical features of schizophrenia with positive symptoms or paranoia. The symptomatology might start with hearing of voices. Do you understand? And now, based on the content of these voices, maybe they're accusing the patient, they are laughing at the patient, they are mocking the patient. Now, it makes sense that delusion might develop. Do you understand? I'm not saying it's always like that, but in some cases, in many cases, they might start having all those sensory distortions. Now, because they don't know what these things are, they remember how we discussed psychosis, that in psychosis there is loss of touch with reality. The individual experiences things that other people don't experience. And now, if you begin to, in clear consciousness, you're hearing people who are conspiring against you, what do you think will happen? You become afraid, you become paranoid, you become deluded. You think that actually, because remember these things are happening in objective space. To them is real. No, it's happening in subjective space, not in objective space. The objective space is our normal reality, whereas the subjective space is the patient's experience. These things are being experienced in the patient's subjective space. Based on that, based on interpretation, because they are perceiving these things, you will now have suspiciousness or delusion. Do you understand? Because they are hearing the voices are causing them. You can now link it, said, after you painted all this, the auditory hallucination, said at about the same time, or a few weeks later, patient was observed by family members to have started becoming suspicious. Do you see how it goes? It's a systematic storytelling. They might not tell you this in this order, but after you've listened to everything, you might be able to link, because it's good that you link it up so that anybody that you're telling the story will actually know that there is a problem. So at about the same time, it was observed by family members who have started becoming suspicious. He started accusing family members, even the mother, of trying to poison his food. Assuming is what happened. Or accusing the mother of blocking his progress. Whatever it is. And remember what we said about delusion. Now, if a patient tells you this, what is the next thing that you're supposed to ask that patient? What's the next thing? That my mom does not want my progress. My mom is working against me. What else are you supposed to ask the patient? Because that's history taking. The patient gives you information, you try to confirm it, you try to know. What else are you going to ask to make sure that this is a delusion and not an overvalued idea? How did you arrive at that? That is the first question. How can your mother want to be against you? How? My mother did this. You just paint one thing. Say, are you really sure? Why would your mother want to do this? Is it not the person that has been catering for you, paying your school fees? Why? No, I know, I'm sure. I even heard the voice. Somebody, it's one of those voices that he was hearing told him that the mother is the root cause. Do you understand? So with this now, you see that this is a delusion because we've shaken it. Who can remember the definition of the delusion that we gave? There's a way I defined it that day. Who can reproduce it for me? Why were you in the class? Who were you in the class? I defined delusion that day. Did I not? What's the problem now? And somebody even defined it. There was somebody that defined it that I clapped for. Who is that? Where is it? Delusion is a false, fixed, and unshakable belief. Delusion is a false, fixed, and unshakable. It's false. Before you start talking about shakeability, it's false. That's the false character. It's false. It's fixed. The person is telling you, the person is saying it convincingly. It's unshakable. Do you understand? That means you have to provide alternate explanations, and the person is still saying no. That's shaking delusion. Strongly held by an individual despite evidence to the contrary, or despite evidence that it is not true, and which is not in keeping with the person's background, which will be social-cultural background, religious background, and so on and so forth. When you're clacking delusion, if we don't see you shaking it, if you don't document that, even when the patient was asked the reason why he believed this, or even when it was explained to the patient that his belief did not make sense based on the fact that so and so, the patient still held fixedly and even said that he heard a voice that told, just find a way of, it's about storytelling, psychopathological storytelling. The idea is that even if you're telling this story to a novice, after telling the story, the other person will know that definitely something is wrong. That's the idea of clacking in psychiatry. Painting behaviors. Just like the most important thing is the reason. Anybody can get angry. Anybody can. In fact, there's a kind of way somebody will get you angry. Some people vent it out, act it out, even destroy things. It doesn't mean that they are mentally unwell. Do you understand? So, but it's about the severity, is it repeated and all that. You paint it in such a way that it will be undoubtedly clear that this behavior is clearly abnormal. That's that. What's the next? What did you document? Yes.
She also said that if she's right, she will be feeling the right one.
Did they teach you hallucination?
Yes.
Do you know about reflex hallucination? Reflex hallucination. What's reflex hallucination? They teach you that. What's reflex hallucination now? Or you can paint it in your own words, or you can give an example. Now, you have a sensation in one modality and you're feeling it in another. You're feeling something in another modality. That's reflex hallucination. Do you understand? Somebody might tell you, if I see this fan turning, I have a crawling sensation. This is sight. This is somatic. Do you understand? Do you understand? Or if I am writing, what did he say? That feeling is somatic now. You know, you have hallucination in all the modalities: auditory hallucination, visual hallucination, tactile hallucination, or somatic hallucination, gustatory hallucination. Which other one? Visual hallucination. Do you understand? When somebody has a sensation as a result that has a temporal, that's timing relationship with another thing, that's reflex hallucination. There's also the one they call extracampine hallucination. Have you heard about it before? Extracampine. When somebody has a hallucination that is not possible based on the person's geographical location. Maybe you're hearing somebody that is giving a lecture in Germany It's not within your sensory space. Do you understand? Or you say, my father just coughed in the village. I heard him cough in the village while you're here. That's extracampine hallucination. When people have lecture, it can happen in schizophrenia or any psychosis, but those ones are rare. People have a lecture 1:30, so we're around now. You have a question? Is it? And it says they lack insights now. Another thing is that they lack insights. That's one key thing. They don't be. Many of them were brought here by force. They didn't know anything was wrong with them. So they don't even believe in your treatment. Not until maybe the psychosis clears and they now start appreciating that, at some point something was wrong. For such a person, and again, a person that had a difficult personality, and that's why when we are taking history, we are very particular about premorbid personality. Have you heard about it before? Premorbid functioning. The kind of personality an individual had has a very big role to play in how the person accepts the treatment. If he's a difficult person, I'm not even talk to you. They are taking, just like he painted, they are taking me here and there. The person doesn't see it as anything that is beneficial. So the person might not give you any meaningful information, and that's why fundamentally the history has issue. All those experiences, hallucinations, they are normal to him. Why would he start presenting it to you as a problem? You should also try to confirm whether he was the only one hearing the voices. Do you understand? If you are asked, were you the only one, you think you are the only one hearing the voices. But for him to have said that, the voices are carried away, it's still a delusional explanation. There's something they call delusional perception. Have you heard about it before? It's part of Schneiderian first rank. Have you read my notes? Schneiderian first rank symptoms. You cannot talk about schizophrenia without talking about Kurt Snyder. He's one of the people that did early works in schizophrenia. And Schneiderian first rank symptoms were seen as something that looks like pathognomonic of schizophrenia in previous classification in ICD-10. In fact, ICD-10 is so much based on Schneiderian first rank. In fact, ICD-10 will tell you that if you pick any of those Schneiderian first rank sets, you can make a diagnosis of schizophrenia. In that Schneiderian first rank syndrome, you have something they call delusional perception. In delusional perception, there is a percept, there's an object which is misinterpreted. For instance, I give you a typical example. Somebody sees two goats fighting. That's a visual percept. And now he gives it an interpretation, a delusional interpretation that, this means that my world has come to an end. Did you get it? Delusional perception. Because these are two normal things that can happen. Two goats can fight. Do you understand? But once the person sees it, something like, gives it a delusional interpretation. There's also the one they call magical thinking. Magical thinking. These things are bizarre. Anytime you start to see bizarre presentations, things that don't make sense at all, it's almost always something that is as severe as schizophrenia. Magical thinking. For instance, somebody starts to withhold. You see somebody, the person is having, the bladder is almost rupturing. He doesn't want to urinate. Why? He believes that if he urinates, that the urine will flood the whole world. Do you understand? It's magical thinking. There is no meaningful relationship between that, what the person is thinking and the reality. Some of these things, like now, what he said that, the wind blows it away, it's too bizarre. All those things, you can bring it up even in the mental state examination, that there is magicality of thinking, and those things will support. So for people that you may not be able to get a coherent history from, you have to rely more on mental state examination findings. Is it? Read the mental state examination findings. Did you ask him how? Always how? Have you met Soludo? Have you met any of the family? Are you in the same? That's part of it. You won't stop at. You won't just conclude. What if they are from the same kindred? Do you understand? Like me now, I'm from Nanka. Soludo is from Isuofia. It's neighboring village. If I tell you now that we are friends, it will sound somehow, but you need to investigate it first. If you don't investigate it, it's not a delusion yet. Auditory hallucination. Is this second person auditory hallucination or third person auditory hallucination?
Second person.
What exactly did he say?
No, they are telling him two people discussing his.
Talking to, that's second person. Continue. But always, at times, patient might not volunteer third person auditory hallucination. Always go ahead and ask, do they also talk about you? Not just to you, do they also discuss you? And of course, in Nigerian first rank symptoms, third person auditory hallucination carries more weight than second person auditory hallucination. In fact, third person auditory hallucination was one of the diagnostic criteria for schizophrenia in ICD-10. Although now it's not that diagnostically important, but clinically, we know that third person auditory hallucination is more suggestive of schizophrenia. All those things can also be, you have to bring in the educational level. If it's a market woman, you can use Nkwo for backward, something like that, bucket days. But if it's somebody who is educated, you can do Syria 7, you can do spell the word backwards. These are the standard ways of assessing attention and concentration. Spell the word backwards, then Syria 7 from 100 to just like that. You just group the whole memory and say memory is not intact. You don't know that you have subdivisions of memory. You have the working memory, you have short-term memory, you have long-term memory, you have immediate memory. Working memory after 5 minutes. The standard way of doing it, for instance, in mini mental state examination, you can give out a name and address. Okole, number 5, Ezius or Street, Enugu. You tell the person to repeat it. That's repetition. In which neurological problem do you have issues with repetition? What is it called? Like this thing I said, and I say repeat it. Okoye, issues of streets. No, 5 issues of streets. If a patient cannot repeat it, what does it mean? What is it called in neurology? Conductive aphasia. Conductive aphasia. And it has to do with a problem with association fibers. I think arcuate fibers. Arcuate fibers that link Broca's area to Wernicke's area. You know about Broca's area and Wernicke's area. What's Wernicke's area? What is Broca's area? Can you remember that? Area what? Brodmann area what? See, you can remember. Is that? Which one is somatosensory area? 312. 312 somatosensory area. Which one is premotor area? Oh, no, motor area. Motor premotor area. 4. Go and confirm. When in conduction aphasia or in conductive aphasia, the patient cannot repeat. Do you understand? It has to do with lesion of the arcuate nerve that links Broca's area to Wernicke's area. So first of all, you test for what's it called now? Repetition, immediate recall. There are 2 schools of thought. Some say, okay, tell the patient that you're going to ask him or her the same question after 5 minutes. Some say, don't say, just distract the patient. That one is to assess working memory. Do you understand? Remember we said that working memory has to do with your ability to hold information, fluidity of information processing and all that. Then after that, you talk about short-term memory. So how can you assess for short-term memory? You can still use that working memory and short-term memory. Then you also have recent memory. Like you can ask the patient what they ate in the night, last night. But there has to be somebody there to corroborate it. Do you understand? Because if the patient is not saying the right thing, there's no way you're going to know. Then after that, you talk about long-term memory. Do you understand? So these are the domains that you talk about under memory. Not just memories intact. So you report each of them. Continue. How do you assess for insight? What are the 4 major questions that you ask to assess for insight? But you know that your cognitive testing or exam is not complete. It's not complete. You have things like abstraction. What did you ask under abstraction? How else can you assess for abstraction? How else can you assess for abstraction? You can tell him to tell you the similarities between 2 fruits, maybe an orange and mango fruits. Do you understand? What are the similarities? And what are the differences? The differences is that the orange fruit has several seeds. Do you understand? Whereas mango fruit has 1 seed. The similarity is that they are both fruits. Do you understand? That's another way of assessing that as for abstraction. Then, did you ask for general fund of knowledge?
Yes, that was what we started asking him about. The president of Nigeria.
Okay.
He answered them with people. He tells me this person, and I think it's like he tells me this person.
So then after that, you go to judgment. Did you assess for judgment? What did you ask? I don't understand. You run towards the light. I don't understand. Come again.
From inside the room.
Inside the room. But yeah, apart from that's fine. Apart from that, there's another standard way, textbook way of assessing for judgment. Who knows that? Who knows that? Who knows that? Other, please, are you cool with us? Are you having we're having another meeting? Tell me about assessment of judgment. A standard way of assessing for judgment. Who knows about running water test? Running water test.
Yes.
So tell me about running water test.
For example, if they enter a room and see that the whole room is flooded and water is rushing,
What would they do?
what would they do?
This one is textbook. This is how we know people that come for clinicals. When you don't need too much to pass clinicals. Once you're coming around, the common things are the things that when you start blowing out this high fellow, we know that you're not coming around. So running water test is the commonest test. But however, the illustration you gave was fine. And then insights, there are standard ways of assessing for insight. About 4 questions that you need to ask. No, you shouldn't be the only one asking. Oga, tell me about insight. Come closer. Tell me about insight. How to assess for insight. Cost awareness of the problem and Okay, so let's make it more practical. One, the first thing that you do is that they said that you were aggressive, you were fighting, you were doing this, you were doing that. Is that true? I said, no, I didn't do all those things. I said, just relax. They wrote it. The people that brought you, look at what they wrote. You go back to presenting complex, depending on whosoever that clacked, you might see aggressive behavior, talking to self, restless, all those abnormal behavior. I said, these are the things that they said you are doing. Is it true? Yes, I did some of them. It's just that they were looking for my trouble. I was trying to defend myself. That's one. He admitted it. Awareness of symptoms or the abnormalities that he presented with. Now, the next one should be, these things that you did, are they right? Do you understand? Did you do it? One, are they proper? Two, I say, okay, well, nothing is wrong with those things. I was only trying to defend myself. I stabbed him. Why did he look for my trouble? Yes, I stabbed him. I stabbed him because he looked for my trouble. You see that the insight has stopped there. Do you understand? But you can still go ahead and ask other ones. So he admitted he did. He stabbed somebody. He adduced a reason that, because I stabbed this person because he looked for my trouble. Or he might say, well, he provoked me. Well, if I have another opportunity, I won't do that. Or maybe I overreacted. Do you understand? He admitted he did it. He admitted the wrongfulness. Do you understand? Now the next one is, what do you think caused it? Are you following it? What do you think caused it? The behavior, the abnormal behavior. Some will tell you, well, it's a spiritual attack, spiritual manipulation, village people. Some will tell you medical condition. Some will tell you, well, mental health issue. Do you understand? That's the third one. What do you think caused it? One is admission of wrongdoing, admission that thing was wrong, stating what caused it, whether it's spiritual, mental, or physical. 4 is the treatment. What do you think is the treatment? How do you think we can handle this? The treatment that you're already receiving, do you think is the proper way of handling it? Now, depending on what the person says was the problem. If it was spiritual, the person will tell you, I beg you should take me away from here. Take me to a Babalawo house for prayer. Take me to pastor. Why are you keeping me in the hospital when I told you that it's a spiritual thing? However, if the person admitted that, it's as a result of mental illness.
But if the person does not admit that what you did is wrong,
that means he doesn't have insight. That's the second level now. Do you understand? Now, the person can admit that I had a mental illness, I had a relapse, and I believe that this is what people are doing for me is the right thing. Do you understand? Some will tell you that they admit that what they did was wrong. However, they should be in the church for prayers. Do you understand that there's no need for medication? Or they should handle it in a traditional way. And definitely, if somebody is telling you that, you know that if you discharge him at that particular point in time, he might not take the drugs, you throw away the drugs. So that's that. And of course, by extension, will the person continue with, if you discharge the patient, will he continue to take the medications and come for checkup and all that? It's basically for about 4 levels of assessment. And it's encouraged that you state it the way they are. You've not reached a level where you say this person is inside, unless the person is fully inside. You can say this person is fully inside. But if there are areas they understand, maybe he accepted that something was that he did it, but however it's in self-defense, he tries to justify it, you just state it the way it is. You understand? Some people will say inside is full, inside is partial. You understand? But it's better to say what you got. You have a question? Because during the course of your treatment, you remember that the treatment that we give is biological, psychological, social. And part of the things that you do in psychological is what we call psychoeducation. You understand? In psychoeducation, you try to explain to the patient what the illness is all about. For instance, if it's schizophrenia, they said you can make it practical. The patient was hearing voices of unseen persons before he was brought. The voices were telling him to fight and all that. And now, during the course of the treatment, the patient is no longer hearing those voices. You can use that to psychoeducate him. Have you now seen that those things were not real voices? It was as a result of a psychological disturbance. Now, why you are no longer hearing those voices? Because you are now taking your drugs. It's the drugs that are making you must have taken even before you assess it. Insight is something that, of course, you assess it intermittently, but it's most important when you're preparing the patient for discharge, for continuity of care. It's expected that before discharge, you must have psychoeducated the patient several times, psychoeducated the family members, explain to them. And the truth is that most psychiatric conditions, especially the ones that present early, have good prognosis, very excellent prognosis. Do you understand? Especially those ones that have positive symptoms. Patient comes in disruptive, it works like magic. Do you understand? Seeing is believing. Even the family members will say, if they had some misgivings, some doubts whether the treatment will work, and now the patient is recovering. Of course, it's less credence to the fact that what you're doing is right. Do you understand? So whatever you tell them, it is your responsibility to educate them, psychoeducate them on what the illness is all about, and the fact that it is orthodox treatment that works. At the end of the day, if the patient is still saying no, it's traditional, but it's not. You tell the patient it's not traditional that brought you here. Do you understand? It is expected that the patient should be able to understand the nature of the illness and the fact that the treatment they are receiving is effective, so that by the time you're discharging, you're sure that at least they'll be taking their medications and not relapse. Is there any other question? I think we'll conclude.